Good afternoon, everyone. I'm happy to present today the first journal club, EANO Youngsters Journal Club of 2026. I'm Antonio Fuentes Fallos, a committee member of the EANO Youngsters. Just for the new ones, I'm going to explain a little bit in what consists this EANO Youngsters Journal Club. It's a 1-hour webinar discussing cutting-edge research, following an interdisciplinary research, sometimes discussing translational papers, clinical papers, or basic ones. Also looking for a lively discussion that I'm going to explain how to participate later, and enhancing the networking opportunities. I want to say that this is not a work of only one person. We are a team that make all the effort to make this possible. And also you can participate on this. You can drop me an email or send me a DM in LinkedIn if you want to present or you have an idea about what paper or work need to be next. Also, before I start, I would like to do some advertisement, just to say that the abstract deadlines have been extended until April 9th. And also that the youngster, we are organizing mentoring, also a scientific session, networking event, and also we have the EANO Youngster Awards. So be posted to the news and be updated. So we are going to start the journal club. For all of you, the previous journal clubs and also this one are going to be posted in YouTube in the EANO channel. And for the lively discussion, don't forget to drop your question in the question and answer box. Okay, not in the chat, because if not, the panelists cannot see the questions. So we are going to start. We are presenting today a paper about the INDIGO clinical trial, the report of the phase 3 trial. And the presenter is going to be Maarten Wijnenga, a neuro-oncologist from the Erasmus MC. Also, we have the pleasure to have as a discussant Juan Sepulveda, medical oncologist and neurologist at Hospital 12 de Octubre of Madrid. Ana Berghoff, medical oncologist and associate professor of Medical University of Vienna. And Stanistlav Lazarev as radiation oncologist and associate professor of the Mount Sinai from New York. Also, it's a pleasure to have as junior discussant Francesco Bruno, neurologist at University and City of Health and Science Hospital in Torino, and Angelo Di Pasquale, medical oncologist from the IRCCS Humanitas Research Hospital in Milano. So thank you all for participating, and now I'm going to give the word to Maarten to start the presentation.
Yes. Thank you. Let me share my screen. Thank you, Antonio. I think you can all see my screen now, right?
Yeah.
So welcome to this journal club, which is titled INDIGO 2.0, the next episode. My name is Maarten Wijnenga. I'm a neurologist, a neuro-oncologist at Erasmus MC Cancer Institute in Rotterdam, the Netherlands. And as Antonio just told us, we are going to discuss this paper, which is a mouthful and was published in Lancet Oncology in December last year. And basically, it's the publication of the secondary and exploratory endpoints from the INDIGO phase 3 trial for vorasidenib versus placebo. And I think we all know this trial and the results of the trial. I won't go into that. What does INDIGO 2.0 mean? There's 6 months of additional double-blind data from the second interim analysis to unblinding, which was published in this paper. We will discuss that. There's updated safety data. And another important part is the assessment of volumetric tumor growth rate, reports on health-related quality of life, neurocognitive function, and seizure control data. And before we start, a quick recap of the INDIGO design. It was or is a phase 3 randomized double-blind placebo-controlled trial that runs in 92 centers worldwide. A little bit more than 300 patients were included, and they were randomized between vorasidenib, 40 milligrams once daily, and placebo. Patients with WHO grade 2 diffuse glioma that had a confirmed IDH1 or IDH2 mutation were included with at least one prior surgery, so tissue confirmed diagnosis, no prior radiotherapy or chemotherapy given, and also there should be no need for immediate radiotherapy or chemotherapy at time of inclusion, and patients had to be in a good clinical condition. And the primary endpoint was progression-free survival, as assessed by a blinded imaging review committee. Secondary endpoints were time to next intervention, tumor growth rate, health-related quality of life, and the exploratory endpoints were neurocognition and seizure activity. First, we go to the updated primary endpoint, which was progression-free survival. And on the left, you can see the Kaplan-Meier curve of the publication in Lancet Oncology, so the updated figure. And on the right, you can see the old figure that was published in the New England Journal of Medicine. And what you can appreciate here is that we have the same signal. There is a benefit for patients treated with vorasidenib in terms of progression-free survival compared to the placebo arm. And with 6 months of additional unblinded follow-up, this signal actually is persistent and maybe even is strengthened. What you can see here is that the median progression-free survival is not reached in the vorasidenib arm versus 11.4 months in the placebo group. The secondary endpoint update, time to next intervention. Basically, that's the same story. The new figure on the left side, the old figure on the right side. And what you can appreciate here is that the signal is still there with 6 months of additional follow-up. That median time to next intervention is not reached in the vorasidenib arm and is 20 months in the placebo arm. And what you can also appreciate is that after 24 months since randomization, in more than 80% of the patients in the vorasidenib arm, no next treatment or intervention was given at time of analysis. Then one of the important other secondary endpoints, tumor growth rate. What you can see here is the results of that analysis. So what you can see in the figure is the change in tumor volume from baseline over time. So since randomization, the red dots are the vorasidenib patients, and the blue dots the placebo patients. And what you can see or appreciate here is that there's a slight decrease in tumor volume change over time, or even some gradual tumor shrinkage in the vorasidenib group, while we see an increase in tumor growth over time in the placebo group. You can also look at it in another way. So basically, this is another figure looking at tumor growth rates. And what you can see here on the figure on the right, on the left side, you see the vorasidenib patients, and on the right side, the patients in the placebo arm. And what is plotted here is per patient, the best percentage in tumor volume change since baseline. And in the top row, you see the analysis between 0 and 6 months after randomization. In the middle row, 0 to 12 months. And in the bottom row, 0 to 24 months. And what you can see is that there is some tumor volume reduction in some patients, and it's modest between 0 to 6 months. And it becomes more evident over time. So after 24 months, you see more patients in the vorasidenib group that show some reduction in tumor volume. But we also have to appreciate that in a substantial part of the placebo group on the right, you also see some sort of volume reduction in some patients, but it does not increase over time. Then in the supplementals, there's another exploratory analysis of tumor volumes for the patients that crossed over from placebo to vorasidenib. And this is data of tumor growth rates before study unblinding. And what you basically can see here is that before crossover in the placebo patients, there's an increase in tumor volume over time in most patients. And then after crossover, so after initiation of vorasidenib, the growth rate declines, which basically is supporting a direct treatment effect of vorasidenib because this is a within patient comparison. Then I think a more difficult part, or at least for me to understand, is the part about the self-reported seizure frequency. This is an exploratory endpoint. It's a post-hoc analysis of the subset of patients that had at least one seizure or more at baseline or in the on-treatment period. And it's good to note that the proportion of seizure-free patients is quite big and was balanced between the treatment arms. So in 76% of the patients in the vorasidenib group, there were no seizures reported in the on-treatment period, compared to 66% in the placebo group. And what you see down below is a table with an analysis of the patients that had at least one or more seizure in the on-treatment period. And on the left, you see the overall population. So 53 patients in the vorasidenib group had one or more seizures, and 55 in the placebo group. And you see that the total on-treatment seizure events are way higher in the placebo group compared to the vorasidenib group in the overall population, which translates into on-treatment seizure rate per person year of around 18 in the vorasidenib group and 51 in the placebo group. And that is a significant, a statistically significant difference. And if you then split it up between the two groups, oligodendrogliomas and astrocytomas, if you first go to the astrocytomas, basically there's not much of a difference, around 19 versus 20 on-treatment seizures per person year compared to placebo, which is not significant. But there's a significant difference in the oligodendroglioma subgroup. So you see 10 seizures per person year in the vorasidenib group versus 71 in the placebo group. And this is a figure to show that this is not likely related or not fully explained by differences in anti-seizure medication or anti-seizure strategy. This is a figure of the total amount of anti-seizure medications at baseline, so 0, 1, or 2 or more, and then the addition of or additional anti-seizure drugs added during the treatment. And what you can appreciate here is that this is balanced between the vorasidenib and the placebo arm. Then briefly, health-related quality of life. This is a summary of the total score of the questionnaire. And what you can basically appreciate here is that baseline quality of life was high in both treatment arms, that we do not see a difference between treatment arms and that there's no deterioration over time during the follow-up period. We have data available from at the moment. The same accounts for neurocognition on multiple domains. There are no differences between the vorasidenib and the placebo arm. And what is also very important, that there is no decline over time during treatment and no difference between these treatment groups, which is of course a very important finding. We also have to keep in mind that the length of the follow-up is still very limited. Quickly, an update on the safety data. There's a lot of information in the supplementary data. The main message is that there's not much change between the initial publication and this update. The safety profile is actually very well, and there are no additional new concerns with this updated data. I have put here the figures of the supplementary figures of the AST and the ALT rises. And what you can see here is that, well, this is well known that we see AST and ALT rises after initiation of vorasidenib. You see it most often in the first cycles, and usually it's reversible. And you can see that here as well. And the data didn't really change also with this 6 months of additional follow-up. But I think it's very important to keep in mind that if you look at the bottom row, that is the number of patients that are in the safety analysis set. And after 24 cycles, there's not much data yet. The amount of patients that are in that analysis is still limited. So it is safe, but the length of the follow-up is not there yet. So in conclusion, progression-free survival and time to next intervention benefits seen at the interim analysis persist and strengthen with longer blinded follow-up, so 6 months additional follow-up. Vorasidenib seems to alter tumor growth kinetics, and IDH inhibition seems to lead to slow growth arrest and maybe even gradual tumor shrinkage, but not a rapid cytoreduction. We do not see a negative impact on quality of life or neurocognition. There seemed to be a reduced seizure burden, especially in the oligodendroglioma subgroup on vorasidenib, and the safety profile is still acceptable and stable with this update. So this is a brief overview of the article, and now, of course, we need to start with the important part of this session, the discussion. And I would like to start the discussion with 4 questions. I think there are many more questions, but I think one of the biggest questions is, how should we translate all these data into daily clinical practice? So how should we select patients for treatment with vorasidenib? I'm really wondering how the panelists think about the reduced seizure burden. If they feel that these data are convincing, what are we looking at? Are we truly looking at a reduced seizure burden because of the vorasidenib, or are we looking at another signal, for instance, signs of progression in the placebo group? Really wondering what the opinions are there. What should we do with tumor growth rates? Are there implications for daily clinical practice? Should we use tumor volume assessments or tumor growth rate assessments in our daily clinical practice? And what about these liver enzymes? Should we keep checking them every 4 weeks, also after 24 cycles, or can we do that less often? I think that is an important question.
Cool, thank you, Maarten. I think that after encourage the people to drop the question in the question and answer box, I think that we can start with the first question. How should we select the patients for vorasidenib treatment? Any one of you have comment on that? Go ahead, Anna.
I'm happy to start because I want to propose here something really maybe mind-blowing. I think we have to accept that it's not only us doing decisions it's also the patients. And I think with choosing the right patient for vorasidenib, we have to go much more in a very detailed process of shared decision making. So we have to take much more into consideration, do our patients want treatment? Do they want it now, or do they want to have it later? And have that as a major argument on decide when and who to treat. And I'm eager to hear what the others think on that, because I think in other aspects of neuro-oncology, the answer is much more clear than in this particular situation, and that we have to take here the wish of the patient much more closer into consideration.
Go ahead, Juan.
Yeah, I fully agree. It's very important that the patient understands all the advantages and disadvantages of this treatment. It's very important also for the patients to understand what is going to happen if we use radiotherapy after the surgery or in the time of the progression after a time of follow-up. And well, I think explaining that to the patient is a main question. It's very, very important for you, the youngsters, to spend time with the patient, explaining the natural history of this disease, and also what could happen in 10 years, 15 years, if we use radiotherapy upfront, because it's very important to preserve the neurocognitive condition here. And it's sometimes very difficult to understand for doctors that are not have no important expertise in this disease, and also for the patients, because they want to control the disease. And well, and they are going to ask you, why, doctor, why aren't you using radiotherapy that is so important, so effective in our tumors? Why are you preferring to delay radiotherapy? And the answer is, well, because radiotherapy can produce important neurocognitive decline in 10 years or in 12 years. And I always explain the patients that this is a long range race, not a speed race.
Yeah. Thanks for inviting me. So I'm a radiation oncologist, so I appreciate everybody for your input here. So I think the first question that we should actually ask is, was this trial actually methodologically flawed? And I would argue that it was. So first of all, this trial was called a phase 3 trial. And as we all know, the phase 3 trial should compare standard of treatment to the experimental intervention. Over here, the standard of treatment was chemoradiation as defined by RTOG 9802, because prior to this trial initiation, nobody in their sane mind would recommend observation for patients with Gross disease, because every single patient on this trial had Gross disease. So observing this patient was, number one, unethical. I think this was a major methodological flaw. Now, the authors claim that some of the low-grade gliomas can be observed because they have indolent behavior. And that might be true, except the data in this very trial proves that that's actually not correct, because 80%, actually 75% of patients, if you look at this exploratory outcome, 75% of the patients progressed at 2 years on placebo, just indicating that this patient should not have been observed in the first place. Number two, vorasidenib has never been tested and examined in the later line of therapy. So allowing crossover and depriving the patients in the placebo arm of the standard of care treatment was also unethical. So not only the patients in the placebo arm were deprived the standard of care chemoradiation first time, and once they progressed, they still received vorasidenib with the efficacy which has not been established. Number three, the premise of the study is that radiation results in a significant neurocognitive dysfunction, right? Except in 2026, with modern technology such as VMAT, IMRT, and with the doses that we know are effective for low-grade gliomas, the probability of significant quality of life altering radiation neurocognitive deficits are very low. In fact, there are no credible evidence to suggest that radiation or low-grade gliomas to the doses, which is usually 50 to 54 gray, will lead to significant neurocognitive decline. I think that's a valid point to ask whether vorasidenib is effective, except you should probably compare it to the standard of care, and your primary endpoint should be neurocognitive preservation, because if the rationale is that vorasidenib permits better neurocognitive sparing, that you should have no trouble proving that point. I always say that painting radiation as a toxic treatment for low-grade gliomas, while overselling modest to negligible INDIGO results, is misleading for patients and physicians. You can even see in this updated results, they're talking about the benefit of tumor growth, a reduction by 1.3%, which is clinically insignificant, and then 14% progressed in placebo. Well, if you let patients with active disease take a sugar pill, of course you can see a tiny radiographic effect. And I don't think this is a breakthrough. It's just a questionable design. So in my book, and then on top of everything, the cost of this drug is $500,000 per year. I have patients reaching out to me asking if they can procure this drug because at a lower price in the United States. And I always say, well, I wouldn't want you to cash out go bankrupt for a drug, the benefit of which has not been established. Well, I think the first question that we should ask, were the patients that were examined in INDIGO trial actually the right patients, and was the design appropriate? So in my clinic, I always say, until a proper phase 3 trial indicating vorasidenib benefit over standard chemoradiation is conducted, this drug shouldn't be used in any setting in the first place. And the other thing is, when you compare the data from RTG 9802, and I know that the cross-trial comparison is not effective, at 2 years, recurrence rate with a standard treatment is at 15%. That is, now we know from INDIGO trial that is 40%, so 15 to 40% as a significant issue that I see here. And the other thing is that we know that observing patients with gross disease leads to inferior outcomes. And RTOG 9802 patients that only received radiation, not even chemo-RT, their overall survival was about 7.5 years, I think. And then with chemo-RT, that survival improved by 4.5 years. So, I think there's a lot of issues with the trial, and I'm thankful to the organizers to invite me to offer my input. I am not enthusiastic with this drug at all, but I would hope that at some point we do have a proper phase 3 trial to demonstrate that this intervention is truly non-inferior to chemoradiation.
Cool. Thank you for your intervention. I think Francesco, something. I think that was before.
Yeah, that was before.
Started.
That's very tough. I mean, it's very hard.
So we give some time to Juan to think about them.
Yeah, no, but maybe I just have very few comments that can be addressed also to Dr. Lazarev. I mean, that's very interesting what he says. I think that it discloses how difficult it is to manage low-grade gliomas, also in terms of clinical evidence, which is very difficult to collect over time, because those are very slowly progressing tumors, so it's very difficult to catch evidence about the efficacy of drugs. I think that what has to be said is that the main purpose of the INDIGO trial wasn't to compare radiochemotherapy versus vorasidenib. So it wasn't the purpose, the aim of the trial. So we will never obtain that kind of answer from the results of INDIGO. And I also think, and that's something that Anna Berghoff already said, it's about selection. So the INDIGO trial wanted to select patients who didn't need immediate radiochemotherapy. So it's not appropriate, I think, to really compare the results we have from the INDIGO trial to the results we have to previous trials that were already, that have been done in the pre-molecular era. So with mixed population of patients, and that's difficult. It's that very difficult from a methodological point of view. And I agree with Dr. Lazarev that maybe that's beyond the INDIGO trial. It's, I think, about selection, and for people, for physicians and researchers that deal with low-grade gliomas, I think it's kind of intuitive that there are people who are not in immediate need of radiochemotherapy. We have to think longitudinally. We have to think about the right timing, which is, I mean, the next question we have to have here when we have a quite easy drug to prescribe, because that's the new challenge when vorasidenib can be given like on a routine basis. So we do have to really select patients, and maybe those answers are not contained in the INDIGO trial. So that's what the community has to do. I think we don't have to be enthusiastic. It's not our role to be enthusiastic. We just have to manage data and clinical challenges. So we have to select patients correctly, and maybe patients who have a quite manageable residual tumor which is not symptomatic. And we, for example, for selected cohort of patients, for example, with oligodendroglioma glioma, we know that they can be treated with observation first and maybe milder approaches of treatment. And maybe we can also postpone radiotherapy in certain patients in order to avoid the late effects of radiotherapy. So we maybe can introduce vorasidenib in this setting. But yeah, it's about selection, I think.
Thanks, Francesco, for your wonderful points. I just want to mention that you mentioned it correctly, that this was not the point to compare to chemo-RT, but the point was to look at the benefit or the value of this drug for patients who didn't need chemoradiation, except every patient on this trial did need radiation therapy, chemoradiation, because they all had gross disease. So any patient who comes to the clinic that has a gross disease after resection or now he has a recurrent disease, standard of treatment is chemoradiation. So the argument that this patient didn't need radiation is already, there's some questions about that. And the actual trial indeed actually proves the point that they did need treatment, because at 2 years, 75% of patients progressed. So that's one thing. And the other thing is, well, we just wanted to look at those indolent patients that were asymptomatic, and maybe we can observe them. But well, except the updated results actually show that there's no difference, right? And quality of life, neurocognitive changes, and psychomotor function, they remained as they were asymptomatic at the time of the diagnosis. They were remained asymptomatic at the time of the follow-up of this trial. So, and the third point is really with the effects of the later effects of the radiation that I would say are overstated in 2026. The radiation fields are tighter, the radiation technology is more conformal, the radiation dose that we prescribe for low-grade gliomas is lower than we initially thought needs to be prescribed. So the late effects of radiation are extremely low. And one last point that I wanted to make is that our goal should not be to keep patients on indefinite cancer treatment. So if we're delaying patients' treatment by a couple of years, 2 to 3 years, and then they still get chemoradiation, so I don't know how much we really added to them. Did we really improve their neurocognitive preservation? We don't know, because the patient will still get chemoradiation. We added a burden of therapy, we added a cost of therapy, but we potentially didn't really affect their overall survival and the quality of life. So these are my issues with this trial.
I think that Wijnenga has different opinions on that.
Yeah, I have a different opinion, because I think it's completely understandable to delay radiotherapy and chemotherapy in patients with residual disease, or even if the tumor growth is not fast. So I think that I agree with the goals and the design of the clinical trial. And I have to tell that it's not so important to start radiotherapy and chemotherapy after a slow progression of the disease, because we have time to repeat MRI if you have doubts, and to reoperate or start radiotherapy later. It's not a problem to delay radiotherapy 6 months, 1 year, or 1 year and a half in these kind of patients. So for me, the design is correct. And for the selection of patients, I would choose for vorasidenib every patient with residual disease or without residual disease that had no contrast enhancement or an aggressive progression before the treatment.
Okay, Anna. So let's
Yeah.
hear Anna. So I know that you want to answer. But...
Yeah, no, I was wondering because all these questions kind of come to the point, what is our goal when we treat patients with IDH mutant glioma? And I personally say, I think a disease that is so long and sometimes so slow, it's really hard to go for a time endpoint. So is the survival 15 or 15.5 years? That is, I think, something that is extremely hard to discuss. So I personally think, and I would love to hear the opinion of Stanistlav on that, what is our goal in these patients? And when I discuss the treatment goals with my patients, I say our goal is that your life is as long as possible, as close as possible to the life of other people of your age group. And certainly, if you received a prolonged therapy, your chances are below that. So we have nice data showing that certainly not a single person, but an overall group of patients receiving chemoradiotherapy have less chances to have a full-time employment and therefore the same value on the job market as patients who are still in a wait and scan or in a follow-up phase. So I personally think it's therefore important that we sequence treatments. Sometimes it's about a few months on and off, but that we sequence treatments and that we try to keep patients as long as possible with the lowest burden on their everyday life. And try to keep them in their job, keep them in their family, also discuss their role in families. And it's much easier to have, you have a different amplitude of what you can bear after a radiotherapy because it's exhausting. It doesn't fall down to numbers in neurocognitive functioning or overall physical functioning, but I think it's like on a broader scale. So I think it's really about talking that what is our goal, and that is not months. It's content.
Yeah, I fully agree with you. The goal is really to keep patients as long as possible alive and doing well for the same age group. With the lowest burden in everyday life. And I completely agree with you, except if you deprive patients with gross disease chemoradiation, you actually shorten their life by 4.5 years. We have the data from RTOG 9802 where patients with high-risk disease lived on average 4.5 years less, so 7.8, 5.5 versus 3.3 years. So you don't give them chemo-RT, patients going to just die sooner. That's number one thing. So by just depriving patients standard of treatment, you're actually shortening their life. Number two, if we believe that these patients with indolent gross disease are truly the ones that may live longer lives, then okay, sure, let's prove that. If this drug vorasidenib is truly transformational, there should be zero trouble proving that point compared to chemoradiation and prove that it is better in terms of quality of life, in terms of neurocognitive preservation, and in terms of PFS and overall survival. Until that data is there, we just assume that this is better. Now, number two, you're sequencing treatment. You're not sequencing treatment, you're adding an additional treatment with side effects, with labs, with cost, financial burden in patients' lives. I'm not sure in Europe how expensive to obtain this drug, how expensive it is. In the States, it may have a certain copay for patients' life. They may have to cash out their retirement fund. And I think it may have an impact on their life. And number three, the assumption that radiation therapy in 2026 is exhausting is grotesquely exaggerated. For most patients with low-grade gliomas who are receiving treatment with IMRT and VMAT with 54 gray in 30 fractions, and I see these patients during treatment and after treatment for years after treatment, and I'm yet to meet a single patient that actually develops significant quality of life impact long-term after treatment. So I have issues with this trial. Prove that the vorasidenib is truly advantageous and superior, or at least non-inferior to chemo-RT in terms of oral survival and quality of life, and then let's make this drug available to all. But until that point, this is just an assumption, and I don't think we're being completely honest with our patients.
I think we have quite a different experience of treatment of patients and also quite a different definition. So I truly believe that there are patients where it's safe to do a wait and scan and do a follow-up. And I truly disagree that there is not a single patient that has side effects from radiotherapy also in modern times. I think we have to conclude with that we disagree. And I think that is also showing something that is quite complex in the whole entire field of treating IDH mutant glioma, that there are different views on that disease. I just wanted to point one more point to the studies that you're referring to, that we nowadays use a new definition. So a 21 WHO defined type 2 glioma is a different disease than what was back then included in the studies. So I think actually referring to these studies nowadays is a little bit of a flaw, because there might be tumors that might be more aggressive, and we don't know how the balance was here between the arms. And as I said, I think it's rather not about just lifetime, but it's really about sequencing and having a sequence in treatments. And I also truly believe that there are still patients where you can safely follow up with scans and they don't need treatment. Then there are patients that profit of vorasidenib. And then there are absolutely clear-cut patients with a significant growth and not a minor growth, as we sometimes see, that really do need radiochemotherapy. And all that needs to be discussed with the patients, because I totally acknowledge that there are patients where I would say vorasidenib might be the right option, but these patients want to have the radiochemotherapy because they want to have a stronger and more effective treatment as for now. And I think that is something we need to acknowledge.
Yeah, RTG 9006 did an analysis of IDH mutant grade 2 glioma, so we have that information, and I agree that the cross-trial comparison is not valid. However, if you look at 2-year time points, that PFS is about 85%, which is 60% on INDIGO. And with side effects, there are acute side effects that happen, but in the grand scheme of things, the long-term side effects are rather rare. And the final point that I'd like to make is that what we believe is irrelevant. I think the most important thing we should look is data. And if we do not have data showing non-inferiority to vorasidenib, we have to be very honest with our patients that we don't know whether this drug is doing what it intends to do with respect to quality of life and overall survival.
Well, Maarten, Francesco, be quick, because as Anna said, this is clear that we disagree between each other. This could be forever, so we need to conclude to read some questions from the question and answer box.
Okay, I'll be very, very quick. Another thing that has changed since the RTG 9802 trial is the extensive surgery. For example, those patients underwent, if you look at data about extensive surgery, about 40% of patients just underwent biopsies, which may have influenced the impact of radiochemotherapy afterwards. So up to today, we not only have a different classification, which is more, molecular based, so more precise. Also, patients are different since the very diagnosis, so they are more likely to have undergone larger surgeries, and so therefore they may have a longer survival for that.
Maarten?
Yes, I think we should agree to disagree. I fully agree with Anna's statement. I would just like to switch questions, if that's possible. And I'm still really curious how the panelists think about this reduced seizure burden. How should we look at those data?
I could read some question and then go to the question about the reduced seizure burden. So first question from the audience: the progression-free survival and time to next intervention in the first 6 months didn't seem very significant. So how can we manage patients during this period? Anyone?
Yes,
Okay.
maybe I can just jump in. Yes, just a brief comment about all we said before. Yes, I think that for the INDIGO trial, the real point is deferring radiation treatment and chemotherapy, and not just have a comparison with chemoradiation, because probably we know that chemoradiation is very effective compared to vorasidenib, but I think the idea under this trial was to defer the use of radiation. And yes, probably the cross-trial comparison is not a good thing in general, but for example, we really don't know if deferring radiation treatment has some kind of impact on overall survival, because For example, we know that in the ORTC 845 trial, the PFS with low-grade gliomas between early or late radiation treatment was different, but in the end, the overall survival for this subset of patients was similar. So probably differing the radiation therapy is not so detrimental on overall survival. And about the question of the panel, so how to manage our patients in this first part of the treatment, so the first 6 months. Probably, I don't know what is our practice, your practice in general, but for example, we started vorasidenib and then follow up our patients with a MRI scan every 3 to 4 months just to have an idea of the tumor growth and have an idea of the course of the disease. So I think this is a manageable way in general to follow up our patients and to see if there are some gliomas with less indolent disease in general. But I'm very curious about your practice in following up the patients with glioma with brain MRI.
In our practice, we follow them with MRIs, usually every 3 to 4 months for the first couple of years, and then we extend follow-up with Q6-month MRIs, a year 3 to 5, and then I usually try to follow them at least once a year after that because we know that late recurrences happen.
So we have another question. Sila Ufuk Karakaya. Do we have data about patients who were operated upon progression under vorasidenib, and how the tumor characteristics change under vorasidenib therapy? Juan, could you answer this question?
Well, I don't think we'd have, that's a very interesting question. I don't think we have data about that. In Turin, we are starting to some projects in order to analyze the tissue after operation in patients who were on vorasidenib in order to assess the molecular signature of the tumors. But yeah, that's an open question. I think that's one next challenge.
Well, thank you, Francesco. So, Maarten, before going, we have 30 minutes, so we can come back to your questions if you want. Like how the reduced seizure burden, how convincing are these exploratory data? What was your question, right?
Yeah, I'm wondering how the panelists look at these data. I think it's a difficult analysis to understand and to translate into clinical practice, for me at least.
Yeah, so I can try. I think also that the seizure data is hard to interpret, and I think time will show. So I think we will need here real world evidence data, how that really works in everyday practice. I nevertheless find it quite interesting that there was the highest impact on seizure control in oligos treated with vorasidenib, and in these patients they do sometimes have quite complicated seizure combinations and medications. So I think it's nothing that is now part of the decision-making process or the indication process, but it's something to keep in mind and certainly interesting for upcoming experience, and if that is something that is an additional argument or not.
Yeah, I think it's normal to see that a drug that is reducing the tumor is improving the seizures of the patients. But the data from the trial are very difficult to understand because it's not one of the main goals of the study, and patients with uncontrolled seizures were excluded from the trial. The registration of the concomitant treatment was not perfect in the trial, but my personal experience in the real world data with real world experience with vorasidenib is very good related with seizure control. I have seen many patients with a very clear reduction in the number of seizures, and I have been able to reduce the dose of antiepileptics in most of the patients without progressive disease under vorasidenib. So I'm happy, and I can tell you that I'm seeing this signal in my patients. I have treated like six patients in the INDIGO trial with vorasidenib, and then in the program access program, I have treated like 20 more patients, and disease control could be a goal and achievable for our patients. Now we don't understand if the seizures improvement is due to the reduction in the tumor burden, or if it is due to the reduction in oncometabolite.
Yeah, I also align with the Dr. Sepulveda comment. I think that there are very strong data about the biological effect that IDH inhibition can have on seizure control due to the role of due to hydroxyglutarate on seizures. In our experience in Turin, we actually saw that there are patients with a very quick and early seizure response after the vorasidenib initiation, which is even faster than tumor control. I mean, seizure control can be achieved in some patients very early, like in 1-2 cycles. In some cases, and I'm considering patients with active seizures at baseline, so with seizures in the month before vorasidenib initiation, which I think is related more to the enzymatic effect of the drug than to the tumor control effect, which takes longer to be seen. But I think that one of the major challenges is that it's very difficult to track seizures over time. So there are the recall bias of patients who are, in some cases, quite unable to recall seizures. In some cases, seizures also alter the consciousness, so it's not easy to really take note of that. In some cases, patients are not treated in neurological centers, so maybe there is no. There are a strong control of clinical signs and symptoms from neurologists. So that's one. It's something that has to be clarified in future trials, of course.
Cool. So we have more questions. Do we have any data? Sorry, from Elias Jesus Ortega. Do we have any data on what happens with subjects who stop Bora for other reason other than progression? Does the tumor progress right away? Is there a lingering effect? Also, any experience on re-challenge? Do they respond again with re-exposition? I think it's one question that's like 4 on it. So we can start with the first one. Do we have any data on what happened with subjects who stop Bora for other reason other than progression disease?
Yeah, I have 2 patients that vorasidenib was interrupted because toxicity, liver toxicity, and both of them had disease progression after 2 or 3 months vorasidenib discontinuation. Yes, could be, tumors can continue growing, but there are no large data about these kind of patients. And regarding a re-challenge, I don't have experience, and I haven't read any paper with retreatment with vorasidenib or other IDH inhibitors.
Cool. Any other experience with re-challenge? Any of you have one? No.
I have some experience with a small COVID infection crisis that we had here last autumn among our patients. So quite a lot of these patients, when they had COVID, they increased with their liver enzymes. And when you re-challenged them, they had quite an increase again, but they were then stably on a lower dosage, and we did not experience any growth in these, I think it was 3 or 4 patients, and they were off up to 3 months from the treatment. So something between 4 weeks, 8 weeks, and I think 9, 10 weeks.
Oh, thank you. So, okay, I'm gonna read. Oh, I already lost this. Okay, I have the last question because we are 5 minutes away. So, following the previous question, what do you think about proton mini beam radiation therapy?
Yeah, great question. So proton radiation is a form of radiation that allows us to minimize dose to healthy tissues because of the different radiobiological, radiophysical characteristics. Because proton beam dose fall off is very sharp, so we're able to deliver radiation to the pre-specified depth anywhere in the body, and the exit dose is negligible on paper. In reality, there's still some low dose. I generally don't prescribe proton beam radiation for low-grade gliomas unless the patients ask for it. There hasn't been a really good study demonstrating its superiority in terms of neurocognitive preservations or any late side effect like pituitary side effects if the tumor is close to the pituitary gland or lower risk of secondary malignancy, for instance, which is another concern with radiation. With conformal radiation techniques that we have today, IMRT and VMAT, the dose fall off to the adjacent healthy brain parenchyma is generally negligible in a sense that most patients do remarkably well with respect to neurocognitive function, quality of life. So unless patients specifically ask, I don't recommend protons, but we do have access to this. So for my pediatric patients, I do usually treat them with protons for other CNS malignancies. Yeah. Great question, though.
So I think that we have time for another one. Maarten, do you want to ask the last question of your presentation about the safety profile? Like, I can do it. Like, how often we should check the liver enzymes in the porcine treated patients?
After 2 years.
After 2 years, I think it's every 3 months in the prescription. So it's every 2 weeks for the first 2 months, then monthly for 2 years, and then every 3 months after that. And that is, I think, written down in the prescription, and I would not discuss that as for now.
Yeah, I think is that every 3 months after 2 years, and I've done that for my patients with no problems. I haven't seen any liver toxicity after 1 or 2 years of treatment.
I agree.
Also,
I agree. Yeah, usually, patients who develop liver enzymes increase are usually likely to develop it in the very first months of treatment. Those who develop a 3-4 CTCAE grade of toxicity. So, yeah.
Yeah, I agree too with this kind of management of liver function test monitoring. Yeah.
Also, thank you. I think that we should go in finishing, so there is no more time for question. Actually, thank you, Anna, because you were answering any question in the question and answer that we don't have time to answer here. Thank you all the panelists, to be here and have such a great discussion with different opinions on the INDIGO trial. And thanks for joining all the attendance, and see you in the next one. Thanks for coming.